Dear ladies and gentlemen, I'm Stefan Achmar from Germany, and together with my co-host Mirwad Al-Aznak from Saudi Arabia, it's my immense pleasure to welcome you to a symposium that's called Acute Coronary Syndrome Long-Term Outcomes in PCI, Raising the Bar. This is a symposium that's sponsored by Elixir, and we'll hear a lot about the bioadaptor technology. And we have fantastic faculty with us today, Michael Havranek from Poland, Stephen Chang from Hong Kong, and Hiwa Ho from Singapore, so that we can look at this important question from a number of different angles. Here you can, I'm just trying to control my slides. Here we go. You can see the program that we have planned for today. So after a brief introduction, we'll hear about the INFINITY-SWEDEHEART data in acute coronary syndrome patients by Michael Havranek. Then we'll have case experience from Singapore in primary PCI and some data. And then finally, 2 cases will be presented, and there will be lots of opportunity for discussion in between. If you have questions that you would like to ask to the presenters, to the panelists, and to the moderators, you can enter them in the chat function of the Zoom, and the question will be forwarded, so then we can address the questions that you might have during the presentation. So feel free and help the symposium by entering your questions. It will make the discussion so much more lively if you can answer your questions. Also, there will be poll questions during the presentations occasionally, so that we get feedback from you, and you will see the first poll question coming up in just a minute. The course objective, as you can see here, is to review the most recent clinical evidence that we have on the new DynamX Bioadaptor from the INFINITY-SWEDEHEART trial and also the Singaporean PPCI trial in acute coronary syndrome patients, and then to have these case-based discussions. So this is the course objectives, which are very much directed towards our daily practice as interventional cardiologists from all over the world. We have participants really from many, many continents, and we're very happy to see this large participation. Let me start with a brief introduction, because there's an important component that we as interventional cardiologists are certainly aware of, but we might not always have it on the very top of our minds. And that's the long-term outcome of the patients that we treat successfully with PCI. And we typically know a lot about the immediate outcome, how we help patients in acute coronary syndromes. We know that performing PCI for revascularization in ACS will reduce events as compared to medical treatment over the first 12 months, definitely. But of course, there are also events related to the revascularization, particularly during the first 12 months. And we often look at the 12-month outcome of various devices that we use. And here you can see from a very nice meta-analysis by Mahesh Matfahan from the New York group, the rates of target lesion failures after bare metal stent implantation, large meta-analysis, many, many trials, thousands of patients. In the first year, 18% target lesion failure, and then the second and the third generation, the first and the second generation drug-eluting stents with significantly lower event rates in the first year. And we're very much aware of this. But when we implant the device into the coronary arteries, we sort of introduce a foreign body into the coronary arteries. And after this 12 months landmark that we are so aware of, events do continue. And here you can see this landmark analysis, meta-analysis, thousands of patients that show that kind of almost independent of the device that was used, events continue to accumulate over the subsequent 5 years. And if you compare the event rates, target lesion failure in the first 12 months, and in the subsequent 5 years, they're almost the same number of events. So there is no stop in target lesion problems that can occur after a device has been implanted. With the bare metal stents and with the drug-eluting stents that we currently have, events do continue. If you look at the 8 to 9% event rate between months 12 and then after 5 years, partly of this, if you have target lesion failure, it's a composite of cardiac death, target vessel MI, and ischemia-driven target lesion revascularization. About 3% of these events are cardiac deaths, but there are about 1 to 2% of stent thrombosis and about 1 to 2% of target vessel MI. So there are events that are associated immediately to the device that has been implanted, and they don't stop. They continue over a long time. Now, this is not something that is limited to a small number of data, but all of the data that we look at, if you compare 1 year follow-up and then you look at 5-year follow-up, long-term follow-up after device implantation into the coronary arteries, again and again, you see approximately the same picture, that the rates after 5 years are approximately twice the rate after 1 year. So the accumulation of events does not stop after we have implanted a stent into the coronary arteries, something that we are not so aware of because in clinical practice, we typically lose sight of our patients after we have successfully treated them. And even in those attempts where, the leave nothing behind theory has been, of course, a very attractive one, either with bioresorbable scaffolds or by simply treating without any stent by drug-coated balloons. And you see the same principle that even after a longer time, events do continue. So leaving nothing behind doesn't seem to solve this problem completely. How can this be? How is manipulation in the vessel, leaving a device behind in the vessel potentially associated and the reason for subsequent events? Well, there's a lot of work that has been done and published and thoughts that have been created that, of course, vessel compliance, the rigidity that is introduced into the vessel in this area will change hemodynamics, particularly as vessels adapt over the course of time and as vessels adapt to the hemodynamic needs. And that this caging of the vessel, the lack of compliance of the coronary artery might be an important reason for hemodynamic consequences, and of course also plaque rupture, the development of vulnerable plaque, atherosclerotic forms, and subsequent events. And this is exactly where, particularly in acute coronary syndromes, we might have a problem, because the adaptation of the device that is implanted to the coronary artery of the patient at the moment of implantation is more difficult in acute coronary syndromes than in stable patients, because there's a certain degree of vasospasm clearly associated with patients who have acute coronary events, and undersizing of the device can easily occur when there's a certain degree of spasm of the vessel that is being treated. And then if the vessel, becomes larger over the course of time, this can be a problem with malapposition, changing the hemodynamics, accumulation of thrombus behind the stent, and particularly in acute coronary syndrome patients, this problem is more than in patients who have stable coronary artery disease. And this is one of the reasons why, of course, we're looking specifically at ACS patients in this seminar and what this new technology can do for us. Talking about new technology, talking about the bioadaptor, the question, of course, that we have in order to get to know the audience that we talk to is, how familiar are you with this new technology? And you will see a poll question coming up now. Do you use the bioadaptor regularly? Sorry, do you use it not regularly, but in selected patients you do? Do you know what it's about, but you haven't actually used it? Are you familiar with it, or somewhat familiar, or not familiar at all? So please, if you can start answering this question now, and we will see what the answers are. So far, I don't see any answers coming in. I don't know whether there is something that the directors in the background need to do so that we can start seeing questions. Just let me know if there's something I should be doing. But at the moment, I don't see an option for me to do something about the question.
So it popped up and we responded.
Okay, maybe we can see the answers to that poll. I saw it for a brief amount of time, but at the moment I can't see it anymore. Here we go. So we see, if we look at the answers, that there are few in the audience who use the bioadaptor regularly, but the majority uses it either in selected cases or, even though being familiar with the technology, haven't actually used it. And then there are some, about a quarter of us, who are not familiar with the bioadaptor technology, but you will be very soon as we go on to the next presentation. And I think what we'll do now is to exactly continue, because we have a very exciting presentation coming up, the very large data set of INFINITY-SWEDEHEART, and the particular analysis of that data set in respect to patients who have an acute coronary syndrome And this exciting data, along with some background information on the bioadapter, will be presented by Michael Havranek from the University of Silesia in Poland, because Stefan James, unfortunately, at the last second, has not been able to participate. But I'm very much looking forward and invite Michael to share his presentation with us so we learn more about the device and we learn more about the exciting data in ACS patients. Michael, please.
Thank you, Stefan, for this kind introduction. It's a great pleasure to present data which were presented in the ACS and the TCT by the INFINITY-SWEDEHEART trial team. So just a few words about the study device. So bioadaptor implant is a novel coronary implant that is designed to adapt the vessel physiology to restore vessel function and address device-related adverse events which were covered by Stefan talk. There are helical sinusoid strands. The strand thickness is 71 micrometers with cobalt chromium approach. The temporarily connected by what's very important bioassembled polymer coating-eluting anti-proliferative agent. The following polymer resorption after 6 months, the helical struts unlocks and separate as it shown on this animation. The mechanism of action of this device somehow connect all issues which were covered by the initial talk. So during the first 6 months, this device works as a regular stent, so it helps to restore flow and achieve high acute gain and low residual percent stenosis. And after the 6 months, the specific feature of this device is starting. So the device is unlocking, as you see in this video. So what leads to restore adaptive remodeling and maintain flow. And this afterwards, this dynamic support with restore hemodynamic modulation and pulsality compliance and adaptive coronary flow. So this issue, which was covered by Stefan in this slide regarding what could be the problem in the post-primary PCI patients. The first initial data, of course, confirms that the restoration of diameter stenosis is comparable to the regular gold standard set also after 1 year. And of what is obvious regarding the mechanism of action of this device, 1 year IVUS result shows that the restoration of pulsality and adaptive coronary flow volume is much better with the DynamX Bioadaptor. I think very interesting slide, which was surprising also for the trialists which conducted the bioadapter RCT. So this is the late percent change in plaque volume, which we can see that there is almost a regression, which is visible on all lesions. And what is very important, and I think somehow may be connected with the results with acute coronary syndrome, and what was pointed out by Professor Affenbach, that this result with positive percent change in plaque volume is mainly pronounced in the lipid-containing lesions, which very often are the cause of the myocardial infarction. The bioadaptor RCT shows, we know at that moment, 12 and 24-month results for 445 patients. This analysis demonstrated safety and efficacy of this platform and the established benchmark in restoring vessel function. As you can see, the curves are definitely positive for this device. The target lesion failure primary endpoint at 12 months was met. With significance for non-inferiority, there was the reduction of plateauing in TVF, TLF through the 2 years, and the novel findings which were shown in the previous slide of plaque stabilization and regression. After this trial, we were facing the really big randomized trial, which was initially showed in the ACS Congress this year, INFINITY-SWEDEHEART RCT. The objective was to evaluate the safety and efficacy of the bioadapter implant compared to the regular DES in the large multi-center RCT. And of course, what is very important regarding the mechanism of action, to evaluate the potential superior clinical benefit after 6 months on reducing non-plateauing events rates compared with the contemporary DES in a representative patient population, including high-risk patients with acute coronary syndromes and complex lesion subsets. The primary endpoint was target lesion failure at 1 year. And there were, of course, several powered secondary endpoints established. The first one for non-inferiority, the primary endpoint, and the second one for superiority. And this superiority landmark secondary endpoint was, of course, calculated for the landmark analysis from the 6 months. There were a lot of centers which in Sweden which were including the patient with the highest number, more than 300 patients in the Umeå University Hospital. Of course, there was imaging core lab to assess the acute results. The key inclusion criteria regards the patient with CCS or ACS indicated for PCI with stent implantation. A few slides regarding the initial analysis, which covers all indications regarding the coronary disease manifestation, and maximum of lesions may be treated during one session. The key exclusion criteria was the lesion in left main, the venous or arterial bypass graft, instant restenosis CTO, and lesions which are less than 3 millimeters from the ostium of the vessel. So the study was designed as a one-to-one randomized trial comparing DynamX Bioadaptor and resolute owners with 100% 12-month follow-up of the included patients. There were at least 1,200 patients in each group. So the patient baseline characteristics include high clinical risk population with prior MI at 12%, prior PCI and at 14, of course, cabbage. As we know that the grafts were excluded, the amount of patients with cabbage was quite low. What is very important, 3/3 of the population was the acute coronary syndrome with 25% of ST elevation myocardial infarction and almost 40% of NST elevation myocardial infarction. So the lesion characteristics subset was also complex with bifurcation, calcified lesion, or also tertious lesion, which could be also the goal for this device. The lesion length was almost 25 millimeters with both groups, and of course we have a great reduction in post-procedure percent diameter stenosis, almost nothing in both groups. So target lesion failure at 12 months, the primary non-inferiority endpoint was met without any problems with huge statistical significance. The rate of dynamics group of primary endpoint was 2.35 versus 2.77 in the Onyx DES group. And the results were consistent regarding the factors which were included in the primary composite endpoint, and target lesion failure, cardiovascular death, target vessel MI, and ischemia-driven TLR. The rate of stent thrombosis was really low in both groups. The power secondary endpoints for 6 to 12 months, I think the most important issues in this regarding this device, as you can see, and we will see it in almost every analysis after 6 months, there is flattening of the curve regarding DES, regarding the bioadapter group, and we still see the same curve which was shown by Professor Stefan Affenbach regarding DES, so slowly growing amount of the events regarding TLF and TDF in this populations of patients. And as we can see coming to the point, so to the ACS patient, the same is for patients with acute coronary syndrome. As you can see, from the 0 to the 6 months, the curves are almost similar, as we have to remember that through the first 6 months, bioadapter is behaving as a regular stent, and after 6 months, you can see that the rate of target lesion failure in the bioadapter group is almost is very, very low, and we see the flattening of this curve. The same is confirmed in the high risk lesion population, like LAD lesions. It is consistent with the bioadapter STD trial that the LAD might be the vessel of choice. If we have to choose the vessel which should be treated, small vessel, the excellent result, almost 0 events in the bioadapter group. The same for the long lesions or lesion with the length bigger than the 22 millimeters. And as we can see, the subgroup analysis, the results are also consistent among all these specified subgroups. So every patient subset has a lot of benefits regarding the bioadapter use. So coming to the conclusion, the INFINITY-SWEDEHEART is a large-scale multi-center RCT comparing bioadapter implant versus DES in a representative clinically complex ischemic population, low and non-inferior target lesion failure rates at 12 months, 2.5 versus 2.8, significant reduction in target lesion failure and target vessel failure, and flattening of the event curves after 6 months in favor of bioadapter in pre-specified landmark analysis. Substantial clinical benefit for the high-risk subgroup, including ACS after 6 months, and pre-specified landmark analysis and consistent effects across pre-specified subgroups, including LAD, small vessel, and long lesion. So evidence from the large-scale INFINITY-SWEDEHEART RCT confirms that the results from the bioadapter RCT trial suggest bioadapter may represent the long-awaited solution for flattened the event curve following PCI, marking a significant advancement in coronary intervention. Thank you.
Well, thank you very much, Michael. This was fascinating with very consistent results, no matter which angle we seem to be looking at this data from INFINITY-SWEDEHEART. I'd like to turn to Mirvat, who potentially has already received some questions from the audience. We can spend a bit of time on this talk and discuss a little bit.
Thank you, Stefan, and thank you, Michal, for the elegant presentation. You know, one thing that caught my attention and probably did come up in the chat several times is the time point of 6 months. So we definitely see plateauing of events happening exactly at 6 months. So how do we explain that? Why the 6-month benchmark here?
So from my perspective, it is directly connected with the mechanism of action of this platform. So we can expect that after 6 months, the strata of the stent are starting to detach, and the vasomotion and the vasomotion of the vessel is restoring. And I think that the confirmation of this approach, so detachment of the vessels of this stent platform struts, is the result in the LAD lesion, because from my end, I think all perspective, the most movable vessel is the LAD, and more tortuous vessel is in LAD. So the effect of the restoration of vasomotion and vessel pulsality probably will be the most pronounced in this particular vessel.
Perhaps, Stefan, I'll ask you this. We saw these subgroup analyses where we had consistent results in all subgroups. So when you're looking at diabetic patients, or you're looking at anatomy, so you're looking at complex anatomy, or you're looking at bifurcations, how do you interpret that with respect to your own practice?
Well, I have to say, first of all, you know, that this entire concept really changed the mindset that I think I have, and we all have, that it's not over after 6 months or 12 months, but we're really implanting something into the coronary arteries. As beneficial as it is, the problems associated with these devices, they don't go away. So that was one thing I think that has become important. And the second one is that if you think about the mechanism of what the bioadapter does, is the release of these struts. First of all, geometrically, it's difficult to imagine, but all the data points that we're really restoring the ability of the vessel to modify its diameter as there's more blood flow, but also to be pulsatile with each heartbeat. So these seem very interesting to see what a consequence this seems to be having. And this is maybe the only conclusion that I can draw from this consistency over so many subgroups, that this seems to be a very central mechanism, much more so than I would ever have expected, that the vessel pulsatility and the hemodynamic adaptation, that's what the data suggests, is really a consistent and very important component of the hemodynamics of the vessel and of the health and potentially disease progression of the vessel. I mean, that's the conclusion that I would draw. I continue to be amazed by this data, but the fact that it's so consistent across subgroups is really, a big comfort that we might seem to be following the right path here. But Stephen, you were also, I think you were also indicating that you have something to say to this topic. Maybe not. Back to you.
Yeah, I was actually going to ask Stephen, acute coronary syndromes, these are technically higher risk populations than, for example, stable patients or chronic coronary syndrome patients. And yet we do see some remarkable data here. What are your thoughts on using this technology in ACS patients, of whom quite a good number are actually STEMI patients, ST elevation MI patients, and not just non-ST elevation MI? And I know you've done several of those cases.
You
I
might need
think
to
you're
unmute,
mute.
Stephen. Yeah. We still can't hear you. You need to unmute. Yeah, here we go.
Is it Singapore you're asking?
So I'm asking about acute coronary syndrome specifically. And you know, these are generally considered higher risk patients. Probably some of them are antiplatelet naive, they haven't been previously on them, and so on. And so there may be reluctance to trial new technology in ACS subgroups. But I know you've been doing it in practice as well, and if you can give us your insights on that.
Yeah, I think for acute coronary syndrome patients, most of the thing we don't know is first is the vessel size. There's quite a lot of components, muscle spasm. Another thing is the anticoagulant or antiplatelets, this kind of things. But for nowadays, I think the antiplatelet, the ticagrelor, and this and the anticoagulants is quite good in nowadays. So compared with previous PCI, we have only Parvest, and we have now better anticoagulant for the PCI. And another thing is so-called the performance of the stent. I think the bioadaptor, this kind of performance is very suitable for the acute coronary syndrome, especially in primary PCI. Because during the primary PCI, we never know the true vessel size. We frequently undersizing the vessel. And so afterward, we frequently undersizing the stent to put in the vessel. So we are doing it. But for the bioadaptor, as you know that the expansion limit is quite large, even for the small tube. 2.5 you can expand it to 4. It is the first good things. And even during the later follow-up, after you see the vessel become the original size, for example, more than 4 mm in size, you can even blow it up after the uncaged element. So I think this
imaging these patients, right? You're using intracoronary imaging to
yes.
size? Okay.
Yes, using intracoronary imaging size, but for during the acute status, even using this intracoronary imaging, we cannot see the true size. But during the follow-up, I can see the true size. Sometimes give you some amazing. It is actually much larger than before. And actually, if and I can sometimes see late acquired malposition because the original sizing of the vessel is too small. So I can see the late acquired malposition due to the growth of the vessel. And sometimes my colleague would like to even blow up the scalpel a little bit, the bioadaptor a little bit to fit this late acquired malposition. But I personally, I don't think we need to do it because no evidence show that it is beneficial. But just I can see this kind of thing. And for those patients that I follow up, I didn't see any ACS event for this so-called late acquired malposition after the patient get the true vessel size.
Fantastic. This is all interesting. We could be continuing this discussion even after the first presentation for a long time because there's so many interesting components. But let's move to the second presentation where we will see even more data presented by Hee-Hwa Ho on primary PCI. And I'm sure that will answer some of our questions, but more questions will come up and we'll have another spirited discussion after that one. So Hee-Hwa Ho from Singapore, Tak Tok Seng Hospital. We're really looking forward to your presentation, and the team now needs to switch to give Hee-Hwa Ho the opportunity to present from his own computer.
Okay, thanks very much, Stephen, for the kind introduction. So first of all, I'd like to thank Elixir for inviting me to share our preliminary experience of using Bioadaptor in primary PCI. So let me just get my slides ready. Sorry.
Yeah, we can see.
So I think we all know that primary PCI is the main stay or treatment of choice when it comes to patients with STEMI. And if you can perform it in a timely fashion And I think majority of patients will receive a drug-eluting stent, and this is class 1 indication by the ESC guidelines. We have many DES on our shelves, but is there any particular DES that may make a difference to your STEMI patients? So I think we're all aware of this BioSTEMI trial that was published in the Lancet, basically comparing the use of Osciro drug-eluting stent versus designs. And what they have shown in their results is that the Osciro stent seems to be superior compared to designs in terms of the target lesion failure rate. But you can appreciate that with over time, a period of 1 year and 2 years, both stents demonstrate that there is an increase in the event rate. So something that has been alluded to, that when you implant a stent, you have stent-related events. And one of the challenges in primary PCI is patients do face the risk of stent thrombosis. So despite using the contemporary stent, even for Osciro, the stent thrombosis rate is 1.7% at 1 year, and it rises up to 2% at 2 years. So a few reasons why this happened, because like what Dr. Chong has mentioned, we tend to undersize when we're doing primary if you're not doing any intracoronary imaging. And there's also the presence of thrombus, flow inflammatory state that leads to delayed arterial healing. So I think there's a clear need for a better stent platform for the STEMI patients. So we all know that the DynamX Bioadaptor has these novel features where it uncages after 6 months. This is when the vessel will regain its vasomotion, and you have the phenomenon of positive adaptive remodeling. However, if you look previously over the last few years, there's no clinical data for the use of bioadaptor in primary PCI. So in Singapore, we perform about close to 500 primary PCIs in a year, and we were curious to know how these stents perform in our high-risk group of patients. So we did a registry back in 2021 up to June last year, and we recruited about 54 patients in our registry. And you can see that mean age is about 57 years old. Majority were male, and majority of patients were inferior STEMI. And I'll say that most of them were single vessel disease and relatively stable. We only had 2 patients with cardiogenic shock. And we did most of our procedures through transradial. And for cardiovascular risk factor, diabetes was prevalent in about 17% of patients. We were quite careful with our preliminary experience, so we used quite a fair bit of imaging, close to about 78% of patients, mainly IVUS. And we also used thrombosuction, especially when patients have a large thrombus burden, and about 3 patients require the use of penumbra. We used quite a fair bit of intracoronary integrin as well, mainly as boluses. So number of stent is 1.1, mean stent diameter is 3.16, and total stent length is about 29.5. So we're happy to share the results for our selected group of 54 patients. At 30 days, there was no event. And at 12 months follow-up, again, there was 0 event. So I think the best way to show this technology is by showing cases. So we shared our results in the TCT AP sometime this year in Korea. So I'm going to show a few case examples of how we use DynamX in the STEMI setting. So first patient, 61-year-old, presented with anterior STEMI. So you can see that after we established flow, there was diffuse LAD disease. So we did imaging and then implanted the DynamX 3538. And this is the final result. We nailed it quite nicely at the ostium. So patient had a CT angiogram at 12 months, and you can see that the stent was widely patent. So second patient, 67 years old, presented with inferior STEMI. So after we established flow, we put down a IVUS catheter to size it, and we delivered the DynamX 3538. You can see that it went down quite easily. So we deployed, and that is the final result. So patient had atypical chest pain, so we brought her back for a restudy angiogram and showed that the stent was widely patent. So as we gain confidence, we started to use it in a bit more complex patient. This is an anterior STEMI. You can see that the patient has a calcified vessel somewhere in the mid-LAD. And we did an IVUS through 360 ring of calcium. We treated it with a shock wave to crack the calcium, as you can see from the IVUS image. and we deployed DynamX 3032, and we got a full expansion. So I think the webinar is about raising the bar for ACS. So this is a case that I did raise recently. This is a 38-year-old gentleman who was playing soccer and he collapsed. And he was basically in a SCI cardiogenic shock class E. So the ECMO team implanted the ECMO, and after that I had to do the angiogram. You can see that he had a clot in the mid-LAD. And I did the penumbra thrombosuction. Again, there was some residual stenosis. So to understand what exactly is happening, I did an OCT, and you can see that the presence of white thrombus and the possible plug rupture. So I decided to implant a DynamX 3518, and that was the final result. So patient recovered well from the cardiogenic shock and cardiac arrest, and he was discharged from hospital. So in conclusion, I would say that our preliminary experience of using DynamX Bioadaptor in primary PCI in our 54 patients has shown to be safe and feasible, and the 1-year MACE rate was about 0%. But I think the caveat is we may have chosen a lower risk group of patients, and which could have accounted for the favorable results. And we need a large RCT to show its long-term safety and efficacy. So I think we are quite reassured to see that for the INFINITY-SWEDEHEART, majority of patients were ACS, and STEMI was about a quarter of patients. And what it has shown to us is that the outcomes is better for the high-risk group of patients after 6 months. So thank you very much for your kind attention.
Thank you very much. Fantastic presentation, very succinct and very impressive examples. And let me once again turn over to Mirvat for the questions.
Thank you very much. So a question did come up about, are you using it a little bit more in ACS settings than conventional agents? So that's one of the questions that came in.
Yeah, I would say that because we have some experience since 2021, so definitely I think we need to do the necessary like thrombosuction, and for us we do imaging. And I think it's important that whenever you have a new technology, you best to have your own internal registry and follow up your patients.
Yeah, definitely. I think that is important to have information. One thing that is very critical in ACS patients is antiplatelet regimens. I do know that they're looking into, I guess, presenting their data, but until then, I'm gonna ask you about your own experience. What are you currently using? What is your default regimen, antiplatelet regimen, in these patients who come in with an ACS and then you subsequently put in a bioadapter technology?
For us, I think for STEMI, we use the patient get loaded with aspirin 300 and ticagrelor in the emergency department. So sometimes, as you all know, the antiplatelet effect orally is not take effect until about 6 to 8 hours. So sometimes I do use intracoronary 2B3As for a short duration for 8 hours, just to cover the, make sure that the patient has 80% platelet inhibition during the vulnerable period.
And how about the duration? I'll open this to the panel. We've seen a definite reduction in clinical events, including thrombotic stent thromboses and probable stent thromboses, definitely plateauing at 6 months. The ESC guidelines are now moving more and more towards an abbreviated regimen in all patients getting drug-eluting stents. But what are your perspectives, everyone?
Michael, you want to start? You need to unmute. Sorry, I'm sorry, Michael. You need to unmute.
Sorry. So I think that at that moment, definitely you have a quite big experience, but the whole community is starting to knowing this device. So I think that at that moment there is no data regarding the shortening of the DAPT in this population of patients. Maybe the mechanism of action will allow us to think that after 6 months it would be possible. But at that moment, I will still recommend the classic approach for the DAPT in this patient.
And that's the approach that was followed in the INFINITY-SWEDEHEART for the ACS patients?
Exactly.
Okay, excellent. So that's the largest data group that we have. So it probably makes a lot of sense to follow there.
Absolutely. So I guess it is evidence-based. So I think there's a poll question as well. Do you think we can put it up for our friends? All right, so if you can see it here, how would you explain the clinical impact of the bioadapter? We sort of discussed it a little bit with the panel and the presenters. Plaque stabilization and plaque reduction in lipid-containing lesions, restoration of hemodynamic modulation, flexibility to compensate in case of undersized implant, other, not clear, not sure. Do you think we can put up the answers, or is it too soon?
Obvious that your answer is a bit predictable, I would say. Yes, number 2, not unexpected.
Yeah, 72%. Okay, I think we do have one more. Am I correct? There's one more question to pop up.
No, not yet at the end, only. No, at the end.
Okay.
Sorry.
And
Sorry.
and I think what we should do really to make sure that we end on time, the discussions are so lively, but let's have a case. Let's have a look at the next case, which will be presented again by Michael from Michael Hawanek from Poland. And you're going to share a case with us, and then we'll see a case by Stephen Chung from Hong Kong. And so it's really exciting. I mean, I think we're really warming up here, and the interest is getting more and more. So, Michael, interesting to see what you have to share.
Thank you so much. As I pointed out, we are starting with this technology, so this is definitely the first experience I have. I have implanted a few of these devices. This one was the first in the acute coronary syndrome. So this case regards really young 42-year-old male admitted due to anterior wall myocardial infarction with recurrent short-term chest pain for several days. The patient was without a typical cardiovascular history from the risk factor that was smoking and glucocorticosteroids, testosterone during the last 3 weeks for the mass building. In the labs, we have really high troponin. There was no other abnormalities. In the physical examination, the patient was also stable. It was acute 1 to 2. Of course, we see the ECG. In the ECG, there is evident myocardial infarction with LV function of 30%. So this case has several steps because this was the initial angiography in which we see occluded LAD. At that moment, we proceed. It was done due to we proceed with the regular stent. We can also appreciate the critical lesion in the left, if the left circumflex. It's because I cannot. So first of all, it was shown by Stephen. We do the thrombectomy, then the balloon angioplasty. Then you can appreciate the flow after the restoration. The flow was quite obstructed, especially by the distal part of the LAD. So then the ES was implanted 3.5, and then after assessing the angiogram, this case was done with about the imaging. You can see also that just before the stent, there is the plaque shift to the proximal part, so the other short ES stent was implanted. So afterwards, you can appreciate the result. The result was maybe not optimal, but quite good. But in the last angio, you can appreciate that we have the TIMI free flow to the distal to the vessel. At the third day, there was the stage procedure where the RCA was physiologically assessed with negative results. So the intervention was discarded. And then the PCI of circumflex was performed. There was, as we are also starting, maybe not regular, but starting with this technology, what was pointed out. So regarding the leaving nothing behind, so we sometimes also try to use the DCB in larger vessels, not only the small one. So we can appreciate the result of the first stenting LAD is quite good. Then we proceed with the NC predilatation and then DCB approach with paclitaxel with excellent result in the circumflex. So the early rehabilitation, as we have a complex program of treatment in the ACS patient, the early rehabilitation started just after the second procedure. That what was, I think, surprising. The cholesterol levels are more or less within the normal range. So as we could expect it in the scientist, such a patient with so advanced atherosclerosis, there will be some issues regarding LDL cholesterol, but there is no. Also, LPA was low, so medication. So we also performed the echo. The echo was better. The LDF was 90% of 39% with apex akinesis and hypokinesis of the lateral wall. This is the mistake. So the ASA was, this is the initial procedure with which were done also with the GP2B3A inhibitors. Then the ticagrelor introduced rosuvastatin and ramipril, and then after the I think 4th day of rehabilitation, the patient complained of the acute chest pain. It was the day 8 of the hospitalization with ECG, anterior ischemia, and depressed flow in the LAD, especially in the distal part. At that moment, we will try to, as I think that the middle part of the LAD and middle distal is really this one which moves very often. So we decided to proceed with and prepare with the bioadaptor platform. In the OCT, I think it's also a little bit surprising because there is not a lot of atherosclerosis. It looks like some kind of thrombus which is occurs on the intima media, which was disrupted. You can also appreciate the result on the right. The initially planted stent is well opposed without any problem. At the site of the occlusion, we can see a dissection, and on the OCT, and also some amount of thrombus. So then we proceed typically because the predilatation of the lesion, of course, is mandatory in this stent implantation. So we proceed with the NC 2.75 according to the vessel diameter finds in the OCT. Then the bioadaptor implantation. Oh, sorry. And we've achieved a really a good flow to the distal part of the LAD. And here you can appreciate also the live OCT run with the exactly results of the implanted stent. So medication in this child was ASA 75 milligram, ticagrelor, rosuvastatin, ramipril, bisoprolol, dapagliflozin, and eplerenone. And to take home message from my perspective, we are discussing it all the time during this case. This was the young patient with early atherosclerosis and unclear cause of this atherosclerosis. As the LAD was the most movable vessel, we decided to implant in the second procedure in the LAD the bioadaptor, just to ensure that the vessel metamorpho prevention could be achievable and long restoration of the vessel capability. And of course, knowing the bioadaptor in ACS in the young population, as we pointed out from the very beginning, at that moment we will use the device in the selected population of patients. So the bioadaptor in ACS in the young patients will be our population of choice. Thank you very much.
Thank you. Great case, Michael. Just a quick question. What is your idea about the mechanism of the medial disruption that we saw in the second? Was it an injury with the wire? Or what is your thought about this? And then, of course, we turn to Mirjam for a question or two before we move on to the last case.
So we are thinking quite a lot about this. So I cannot exclude that this glucosteroids in the high doses before 3 weeks before this MI somehow contribute to this disruption, because as we analyze the OCT, there is really not a lot of a big plaque volume. So I would such, from my perspective, I think that this glucocorticosteroid, high doses glucocorticosteroids may contribute to this intima disruption. So this is my final thought. But of course, it's just the concept. Not, I'm not definitely sure that it works like that.
Great thought, definitely. Mirjam, how about questions? Or one question?
Yes, so,
we need to make sure we stay on time.
yeah, just one question, and I think it's a technical one for those of us who are still in the learning curve of using this technology. Is there a problem with post-dilating these stents or scaffolds, and the integrity of this uncaging you know, if you end up using with the conventional drug-eluting stents, you look at the expansion rate, and then you can go ahead and use a bigger post-dilatation balloon. Does this at all disrupt the uncaging of bioadaptor if you go with a post-dil? And
so I was following some really tough cases with the bioadapter regarding especially bifurcation, and because I have the same remarks regarding, for example, bifurcation, the really high pressure post dilatation with the pot and repot, and all these things which made the story distraught. So there is no signal, any signal that we should proceed different in this case than with the regular stents. I think that the Asian experience is much higher, so probably you have some thoughts regarding this issue.
Yeah, maybe.
But from my perspective, there is nothing we have to think about regarding the post dilatation.
Maybe a quick answer by Hir Ho, and then we move on to Stephen Chang.
Okay.
I think post-dilatation for me is kind of routine whenever I implant something. And so as long as you stay within the range, because if you exceed the range, then you can fracture and then damage the implant or the stent. For me, almost always 100% post-dilatation. I think for us, I think because we are imaging guided, so we know our expansion limits. But of course, we have to look at the implant expansion range as well.
Excellent. Very
Same
good.
myself.
Yeah, let's move on to the last case by Stephen Chang from the United Christian Hospital in Hong Kong. Really excited to hear about your experience.
Okay, thank you. Thank you. And nothing to disclose. So, so I think first question that everyone may ask is, which kind of patient is suitable for bioadaptor? This is what I'm thinking, and I think that because of the specific design of uncaged element, the STEMI and also ACS patient is actually really suitable for the bioadaptor, and because the uncaged element also the variable size of vessel and uncertainty during the primary PCI setting. And our usage also has a STEMI registry, but I think different from the Dr. Ho is that we are recruiting even higher risk patients. Our mean risk score is quite high, and we also have some patients in cardiogenic shock. And actually, I can tell you that the results are also excellent. We don't have a 6-month target lesion failure for all these patients. Although some of patients have MACE event, but it is not related to the lesion we tackle. So without going in deep, I would like to share my case. First is a 79-year-old lady. Her presentation is inferior STEMI and also is complete heart block and also right heart failure. And this is the angiogram. You can see that there's a distal left main disease, but this is not the lesion that we are going to tackle. And this is what we are going to tackle is RCA occlusion. It is complete occlusion from the ostium. And also, after I have carefully serving the RCA with the run-through wire, and I can see there's a filling defects, and which indicates there's heavy humpus low. And we use the small balloon gentle prober to the RCA first, and also we put the thrombectomy, and then we can see TIMI2 fold, and we use IFUS to assess this patient, and we saw that it is diffuse long lesion of RCA and also bifurcation at distal RCA Medina 111 bifurcation. Lucky it is not calcific vessel. So for this patient, it is a long lesion and bifurcation, and also we are in STEMI situation, and also this vessel size is really uncertain. So I'm thinking about the bioadaptor for this patient, and I would like to perform 2 stent technique also to preserve the bifurcation. So I have to put a small tube in in PDA and distal RCA, and also a large tube from the PL and distal RCA, and we prefer a modified DK culotte for this distal RCA stenting. And after tackle the proximal RCA also, this is the result. I think it's quite acceptable for this patient, and although the flow is not very good, it's only TIMI2 to 3, the complete heart block resolved and hemodynamic improved. So I think, and also the IFIS showed that the distal RCA stent and PL and PDA is well opposed, and also expansion is very good. So I think we should let the patient home and have early PCI later with this angio result. And 2 months later, we bring back the patient for the restudy, and we see that the RCA really go up, and the RV is also improving in function. You can see the contraction of the vessels, and we compare with the angio of the index procedure and the 2 months. The bifurcation is preserved no eye sound, but there's little luminal gain. And from the OCT finding, the scalpel, the bioadaptor is well endothelialized. And we have partial gain of motor function because it's only 2 months, so we don't have significant change of motor function. So this is the second case. And it is a 58-year-old gentleman. Presentation is anterior STEMI cardiogenic shock. And it is extensive anterior STEMI. And from the angiogram, you can see that it is a left main infarct, acute occlusion of left main, and RC only mild disease. And I carefully wire the LED and left main, and with a gentle profile to the left main to get at least some blood flow to the LED first, and then we rewire the remaining vessels, and with IFIS assessment for the lesions. Actually, again, it is a very long diffuse lesion for LED circumflex and also left main disease. And actually, it is also 111 Medina bifurcation lesion, and it is and this patient has wide range of the vessel size. You can see the left main from 4.5, and also LED is 3.5 and circumflex 2.75. Wide range of vessel size, and the culprit lesion is the left main. So I would like to simplify the procedure with a culprit lesion only to do the primary PS for left main, LED, and circumflex. So again, young patient, bifurcation, and also variable vessel size. I'm thinking about the bioadaptor also. So further preparation of the lesion, and we put a small tube from circumflex to left main, and then we further post-dilate, and we do the first kiss with V5 and VO NC, and then we can put another bioadaptor to the left main and LED. I deliberately not to touch the LED and D1 bifurcation to avoid tackle 2 bifurcation at the same time. So after we post-dilate and also do the second kiss, and also do the final port for the left main, this is the final outcome. I think the stent configuration quite good. And also this is the angiogram afterward. I think we are very happy about this result already, and the patient already symptom improved and also hemodynamic stabilized. We would like to go this time. Of course, I didn't forget to take a beautiful OCT image, show that the good position of the stent, the scalpel. And we take back the patient in 6 months and to do the stage procedure, and we look for the bifurcation. You can see the bifurcation is well preserved, and the bioadaptor is endothelialized after the 6 months, and there's not much ISR. And we have the luxury to bring back the patient in 15 months also to see this bifurcation again, and we see the bioadaptor is also well preserved for bifurcation, and we see there's not much ISR for the bioadaptors. We may see some on the circumflex or ostium, so like other tooth stent technique, but it is hemodynamic not significant. But for interesting thing is that during the 6 months and the 15 months, we use the stationary OCT. You can see the pulse time movement of the LED and circumflex, and even the left main 2 adapter overlap area. And also, if you use OCT, you can see that the pulse time movement more obvious for 6 month outcome, for the 15-month outcomes. And this beautiful technique we also published in JET Intervention for your reference. And so from our take-home messages. For long-term follow-up suggests that Bioadaptor has the ability to adapt the vessel motor function. And the implantation technique, like our demonstration, is similar to the best-in-class DES. And a unique unlock design modify and even improve the outcome of complex PCI, especially in the bifurcation PCI, especially for the QLOC technique. And for our local study, actually, we show that the Bioadaptor performance excellent in ACS patient and even in high-risk ACS patient, and also in a wide range of complex lesion. And also the OCT image show that there's some part regression and nominal gain, and also additional correlation in 15-month studies. Thank you.
Thank you very much. I think this case clearly shows, the cases in particular, the last one clearly shows all the things that can be done with the Bioadaptor. Our time is up, so let me turn to Mirwad Al-Asnaq for a few last words before we wrap up the symposium.
I mean, it's an exciting technology that we see tremendous potential for, particularly as we're seeing event rates fall and plateau after a certain period of time, unlike the conventional platforms. It is a large study that was promising in acute coronary syndromes, but I do think we need to tease out certain groups of patients, particularly some of the questions that I saw in the chat about bifurcations, the ease of re-access of the side branch, sizing of balloons and stents in those kind of scenarios, and just getting comfortable with the post-dilatation and overexpansion of the technology. And I think for me in particular, I really want to know if I can abbreviate my antiplatelets. Over to you, Stefan. Thank you.
Well, thank you very much. I think you summarized it perfectly. Thank you so much to Michael, Stephen, and Hirwa for their fantastic presentations. Mirwad, for your excellent moderation and the questions you brought in. We learned a lot about the technology, about the data that we have, and about clinical applications. And I would like to thank everyone sincerely for participating in this symposium. Have a nice evening or a nice day, depending on where you are.